Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody. Hello friends, and I'm taking classes to make FIGO classification of different kinds of cancers easier for you. And today I'm trying to bring to you now ovarian carcinoma. Now, I just took a class on cervical carcinoma. I tried to make it more simple and easy by telling you just to apply logic and yourself decide what will be the next stage. In the similar way, I bring to you ovarian carcinoma, in which again I'll give you the logic and you will see yourself understanding and applying your knowledge to understand why and how these stages are important. Now, the spread of cervical carcinoma was basically through the lymphatic route or the hematogenous route. So basically the lymphatic channel or the hematogenous channels you'll follow, and you'll understand that fine, stage 1 will be to the cervix, limited to the cervix. The cervix is going to, where will the cancer spread? It will spread either down or it will spread laterally. So that's how we designed the stages, and that's how we understand why we had so much division and subdivision into stage 1A, A1 and A2. Again, I told you. Now let's just forget it over there and let's now start thinking about the next carcinoma, which is the most ambiguous, strange and difficult carcinoma staging to remember, and that is ovarian carcinoma. So ovarian carcinoma staging, do you see that I've not made any effort to make any structures, I've not made uterus or cervix or fallopian tubes over here. It's just a very nutshell over here, just a small portion of it. Why? Because that's the magnanimity of ovarian cancer. It spreads fast. It's got vague symptoms. It's the most lethal cancer because by the time you catch it, it's already disseminated and spread to, far away distant places, and you are in a very poor prognostic stage to be treated. So that's why ovarian carcinoma happens to be a very, very important carcinoma to understand. Plus, it's a staging. When I try to explain you the staging, you'll understand how different the staging is as compared to the other tumors. So let's begin with ovarian carcinoma and let's see its staging. So we start with stage 1. Okay, let me give you an outset, a brief, rough estimate of how ovarian carcinoma is, like I gave you in your cervical staging as well. Always remember that stage 1 is limited to the ovaries. One or both the ovaries is stage 1. Just limited to the ovary, whether capsule intact, capsule breached. And I'll tell you one more thing in stage 1 which you have to remember. Positive ascitic fluid is stage 1. If only it is that much is involved, nowhere else is involved. But it's very strange. But yeah, peritoneal cytology positive stage 1. 1A, B, C, that I'll tell you later. But stage 1, that means I'm talking about ovarian carcinoma. Stage 1 means limited to the ovaries, and maximum it has gone to the peritoneal fluid because that's the mode of spread of ovarian carcinoma. It spreads through the coelomic spread or the peritoneal fluid. Just imagine if you put fluid inside. If the patient is standing, sitting, whatever, the patient is in erect posture, and you put some fluid inside the peritoneal cavity or the peritoneal cavity, where is it going to seep? It's going to seep in the pelvic fluid. In the pelvis. It will go down first because of the gravity. It will go down first. So it will kind of encompass all the organs which are around pelvis. That means POD, the uterosacrals, the part of upper vagina, or bladder, rectum. And then when the patient is moving about, sitting, lying down, getting up, then this fluid is going to go to the abdominal cavity. It's going to probably spread there, in the abdominal cavity, including the retroperitoneal lymph nodes as well. Of course, the pelvic lymph node chain is involved, omentum, and so many structures. In fact, the capsule of liver, capsule of spleen, any peritoneal deposit in the abdominal cavity, and then it will gush even further. That is to the like for example, I put the peritoneal fluid inside the patient's peritoneum, and I put in it a couple of seeds. Let's just say, let's call them seeds or something. So the maximum is going to be deposited in the pelvis. Patient is going to lie down on something. It might, less of them will deposit in the peritoneal cavity, and even less will go farther away, washed away, because of density. The gravitational pull is somewhere in the area very close by. And the similar thing, this is what happens. Similar episode, similar spread is seen in ovarian carcinoma. What happens is that the seeding starts from the ovary and it's just shed. Once the capsule is breached, the seeds are like shed in the pelvic area. When that pelvic area, whatever may be the reason, if there is fluid around or serous fluid starts coming out, and then these things are washed away slowly towards the abdominal cavity. So this becomes the stage 2. That was the stage 1. Stage 2 is the pelvic involvement. All those structures that you can think of. Bladder and rectum is also involved. That is the most important thing of ovarian carcinoma, that the pelvic structures means all the pelvic structures over here. The contiguous spread to the serosa, to the serosa of the bladder, of the rectum, of the peritoneal fluid, the parametrium, the uterosacrals, everything in the pelvic area, stage 2. When the patient is like, it's spreading even further, it's going to go in the abdominal cavity, which I just said, microscopic seeds or macroscopic seeds. Retroperitoneal lymph nodes being automatically involved because that channel will automatically come. Hematogenous and lymphatic spread is going to come by the time it's already stage 3. No, don't doubt that. And then comes stage 4, in which the pleural effusion starts taking place, or the hepatic parenchyma is involved, the splenic parenchyma is involved. That is the stage 4. Now let's go into the subdivisions. So remember one thing, that stage 1 and stage 3 are the 2 stages in which you have to say A, B, C. In stage 2 and stage 4 it will be only A and B. And stage 2 and 4 are still easier stages. Stage 1 and stage 3 are difficult stages. Out of which stage 1 is also, I'll make it very easy for you. Stage 3 you'll have to try to remember a little because it's slightly complicated. Now stage 1, A and B and C. So stage A is limited to just one ovary. Stage B is limited to both ovaries. And stage 3 is divided to 3 categories in which there is surgical spill. So up till now, limited to one ovary or limited to both the ovaries. 3 things were satisfied. There was no capsular breach. There was no ascitic fluid. And obviously there was no spill. Be it iatrogenic, be it because of whatever, there was no tumor on the surface. So the capsule was intact. There was no tumor on the outer surface, and there was no positive seed in the of malignant cells in the peritoneal fluid. Because of which you were very sure that you can give her a chance by simple oophorectomy. Unilateral or bilateral oophorectomy, you do not have to take out the uterus. And you might not have to do a very, aggressive surgical treatment in this patient. You can give her a chance provided all these 3 things are satisfied. There is no tumor on the external surface because the seedings will start after that. There is no capsular breach, and obviously there is no peritoneal cytology positive for the malignant cells. Stage 2. When you come to stage 2, and I'm sorry. So let's go back to this. Stage C I did not describe you. Stage C, 1 becomes there is a surgical spill. Stage 2 becomes either there are malignant cells on the surface or there was the capsulus breached. And stage 3 becomes the positive malignant cells in the cytologic sample of ascitic fluid. That means you tap the ascitic fluid and it came positive for malignant cell. That becomes stage 1C. Stage 1C, 3. Now we go to stage 2. When I said all these pelvic organs are involved. So stage 2A will become only when either the fallopian tubes or uterus is involved. Obviously, it's contiguous spread. Where will it go? It will go first to the tubes, then it will go to the uterus. You think yourself, right? And then it will start spreading to the rest of the organs of the pelvis, which is stage 2B. So all the other organs involved, the organs which are close by, the bladder serosa or the rectal serosa, the parametrium, the uterosacrals, the pouch of Douglas, all this is what? Pelvic organs surrounding the ovaries. So that is stage 2B. Now comes a difficult stage, which is stage 3. That is why I've written it in short so that you can understand it. So stage 3 is actually the spread to the abdominal cavity. And what are you basically bothered in abdominal cavity? I want to see what is the tumor load in the abdominal cavity. So if the omentum is involved, how big deposits are there on the omentum. I want to see that. Whether they are more than 2 centimeters, whether they are less than 2 centimeters, or whether this microscopic seedings, which I just got to know because I had sampled the omentum. So you do omentectomy when you're doing staging laparotomy, you always say that, right? That's simply because of the fact of the spread of the ovarian cancer. It does not go by a hematogenous or lymphatic route. It goes by direct seeding coelomic spread. So omentum is very easily involved, right? So what we do basically is we do, intracholeic omentectomy, or let's say omentectomy for that matter, and we do send it for biopsy. So if there are deposits, that means we're talking about stage 3 over here. And how do we divide into stage A, B, C? Positive retroperitoneal lymph nodes. Okay, positive retroperitoneal lymph nodes with or without micromets. That means you're always sampling the lymph nodes over here. And if suppose retroperitoneal lymph nodes are coming positive, that's definite stage 3, but at the same time it's incomplete if you do not tell me what is the peritoneal deposits, whether they're microscopic or they're macroscopic. Because if retroperitoneal lymph nodes are positive and there are macroscopic deposits, it becomes stage 3C, which, with the prognosis which is not very good. I don't say stage 3 is super good, but stage 3C is even worse. So for counseling, for follow-up, for recurrence, for everything, for adjuvant therapy, you have to know the staging beforehand, because everything depends on that. So stage 3A is positive retroperitoneal lymph nodes, but only microscopic deposits in the peritoneum. Macroscopic deposit starts from stage B, but still they are less than 2 centimeters with or without retroperitoneal lymph nodes. So you understanding that these macroscopic deposits by itself are very important prognostic factors with or without retroperitoneal lymph nodes, which is stage 3C. Macroscopic deposits in peritoneal cavity with or without retroperitoneal lymph nodes positive. And then comes stage 4, stage 4A and stage 4B, which is so different from rest of the cancers. Stage 4A is pleural effusion. Stage 4 is pleural effusion, it goes to the lung cavity, which is positive for malignant cells. And stage B is hepatic or splenic. Now, one thing which I should mention over here right now is I've written something like extension to the capsule of the liver and spleen. So by the time the capsule of the liver and spleen is involved, that is still stage 3. 3B or 3C, both of them, the capsular involvement is possible. But if it goes to the parenchyma, see, this is the liver, right? That is the capsule. So till the capsule is involved, stage 3. But if it goes here in the parenchyma, stage 4, that too stage 4B, worse prognosis. So hepatic, splenic, parenchymal involvement, or the involvement of lymph nodes outside abdominal cavity. Outside abdominal cavity, that means I'm talking about inguinal lymph nodes. So very, very important when the examiner is going to ask you in the exams regarding this. What else will you examine when you're examining a patient of abdominal lump? Would you examine something else locally? Would you examine something else locally? And people are, what the hell does he want to hear from us? It's inguinal lymph node examination. Why? Because if inguinal lymph nodes are palpable, that means they are involved, and it's automatic stage 4B, very poor prognosis for ovarian cancer patients. So even after debulking and chemotherapy and everything, it's actually basically a palliative treatment for such patients. It's already stage 4B. What else will you do? So, your supraclavicular lymph node involvement, linguinal lymph node involvement. These are all involvement of lymph nodes outside the abdominal cavity. So very, very poor prognosis. And with this, we finish ovarian carcinoma staging. I hope you've understood. Like I would say again, please, strongly, I would recommend, after seeing this class, just go and read it yourself. And I'm very sure this thing will always stick to your head. You might not get confused. And remember one thing, any stage that you're getting confused with, write that stage first. Remember only that stage first. And the rest stages you can, kind of fashion along with it. Once you know this stage 3C, which is the most difficult stage, you can easily make stage 1 and stage 2. Well, that's my funda. Everybody has a different funda, and I'm sure you will get your own if you just revise it once and twice with me after this class. So I'll see you next in the FIGO staging of C endometrium, which is the easiest of